Assalamualaikum everyone. This is Dr. Hira Salman. Welcome to our session 4, and these are all the topics which we are going to cover today. So let's start with the first one, Cushing disease. We are going to cover this from main MTB. So let me project this one, page number 121. Okay. So see, whenever it says Cushing syndrome or Cushing disease or hypercortisolism, so these are almost same. All means they are all similar. They are all interchangeably terms. We can say hypercortisolism, we can say Cushing disease, we can say Cushing syndrome. But what is actually the difference between Cushing syndrome and Cushing disease? When we say Cushing disease, it is particularly the overproduction of adrenocorticotropic hormone from the pituitary gland. Normally the axis is like that. Hypothalamus is our master gland, right? Hypothalamus always release corticotrophic releasing hormone, and it asks pituitary to release adrenocorticotropic hormone. Once adrenocorticotropic hormone is released, it's going to act on adrenal gland and it will ask adrenal gland to secrete cortisol. So this is how the whole thing works. First of all, hypothalamus released corticotrophic releasing hormone. That corticotrophic releasing hormone is going to act on pituitary and it will ask pituitary to release adrenocorticotropic hormone. When ACTH is released, it's going to act on adrenal gland and it asks adrenal gland to secrete cortisol. And once the level of cortisol is rising, it will go and produce a negative feedback and it will inhibit pituitary and ask them to stop releasing this ACTH. So this is how the whole things work. So whenever we say Cushing disease, it means that always think about that this ACTH is releasing in.
Dr. Hira, sorry to interrupt,
Yes,
but
yes.
I can't see the notes screen.
You cannot see?
Yeah,
Okay,
yeah.
sorry. Let me share it. Now can you see?
And now it's visible.
Okay, thank you. Thank you for informing. Okay, so I was just telling you that all these terms, when it says hypercortisolism, when it says Cushing disease, or when we say Cushing syndrome, these are almost the same terminologies. But a little difference between this Cushing disease and Cushing syndrome is that whenever we say Cushing disease, it's purely we are meaning that we are referring it to pituitary gland. Like pituitary gland is secreting too much amount of ACTH. That's the overproduction of ACTH. That term is called actually Cushing disease. But when we say hypercortisolism, it means that too much amount of cortisol is there, and that cortisol may be because of the pituitary or maybe because of the adrenal gland. Because cortisol, now why because of the pituitary and why because of the adrenal gland? Because sometimes it's very obvious that once ACTH is released from the pituitary, it is going to act on adrenal gland and it will say adrenal gland to release cortisol. But sometimes whenever there is a tumor of the adrenal gland or maybe somewhere else like ectopic foci and cortisol is releasing from there at that site, it means that cortisol level is going to be rising. So simple hypercortisolism means that too much cortisol. We don't bother whether this cortisol is coming from the order from the pituitary in terms of ACTH, that ACTH is released from the pituitary and then it will ask adrenal gland to secrete cortisol, or maybe it's a tumor inside the adrenal gland which is secreting by itself. There is no order from the pituitary. There is, of course, order from the pituitary in terms of ACTH, but sometimes whenever there is tumor inside the adrenal gland or whenever there are any ectopic foci from where the cortisol is releasing, so thereby we're having too much amount of cortisol in the blood, and that term is called hypercortisolism, and that term is called Cushing syndrome. But whenever we are only focused on pituitary gland, that you are the main cause for secreting too much amount of ACTH, and because of that too much amount of ACTH, too much amount of cortisol will be releasing and the cortisol number will be rising, that term is known as only Cushing disease. So are you getting me? You should know the difference between Cushing syndrome and Cushing disease. When it comes to disease, it's only a disease inside the pituitary that is responsible for secreting too much amount of ACTH. But when we say syndrome, it means only the cortisol is rising. Whether maybe because of the pituitary, because it's releasing too much ACTH and ACTH is asking too much from the adrenal gland to release cortisol, or maybe there is any other ectopic foci because of that, or maybe tumor inside the adrenal gland which is thereby causing too much amount of cortisol. Only the cortisol is rising, hypercortisolism. So if that point is clear, so mostly the questions are based on whether you are able to detect the disease in the pituitary, that is the overproduction of ACTH, or whether you are able to detect that it's inside the adrenal gland there is pathology, or maybe some other ectopic foci that actually cause an increased amount of cortisol. So mostly questions are based on this, and of course question will be clinical presentation, what will be the findings, what will be the presentation, sign and symptoms in the patient that we are going to answer. So if we are considering the presentation, it's very obvious from the scenario point of view, from the recall point of view, you can easily get the clue that, okay, this is a case of Cushing. Moon face will be mentioned, the buffalo hump will be there because there will be a fat redistribution. Think about the cortisol, the functions of the cortisol. The whole metabolism depends on cortisol. So whenever there is too much amount of cortisol, you will see lots of disturbance in the body. If we are considering stria, yeah. If you're considering about skin, there will be too much bruising. There will be wound healing will be delayed. The skin will be very thinned. So that is actually the effect of this cortisol. Cortisol on bones can cause osteoporosis. Cortisol can cause increase in blood pressure, can cause menstrual disorder, can cause erectile disorder, can cause cognitive disturbance, and can cause too much amount of urine. That is maybe polyuria because of hyperglycemia and increased free water clearance. So all of these things are just because of increased amount of cortisol. Now, the important thing for our recall point of view is that how you're going to diagnose this one. So whenever the question is asking you the best initial test, we can always go for 24-hour urine cortisol. So if there is too much amount of cortisol, definitely that cortisol is going to be excreted into the urine. And when you collect the 24-hour urine and then check the amount of cortisol in the urine, that will be high. So it will pointing us towards that's a hypercortisolism. Let me admit them. Okay. So next we have this one. There are now 24-hour urine cortisol is more specific test as compared to any other test, but we can also go for 1 milligram overnight suppression testing, from where we can give this dexamethasone from outside. And if this dexamethasone, it's just like acting like a cortisol, and it will act on the pituitary and it will stop the production of ACTH. So we will get to know, but this is not very specific test, especially this 1 milligram. If we are considering both of these tests, 24-hour urine cortisol and 1 milligram, we will better go for 24 hours urine cortisol testing. So if we are considering this one, now see, this is very important. You should know the negative feedback mechanism. Like when the level of the cortisol is rising, it will go and it will ask pituitary to stop secreting ACTH. Okay. So here they are saying ACTH testing is the best initial test to determine. Now, if there is decreased ACTH, that means adrenal source is there. Why adrenal source is there? If anyone can interpret this one. This is very important. This is very important pathophysiology depending on the negative feedback. When there is decreased ACTH level, there will be adrenal source. How come it that? Say for example, if you are thinking that pituitary,
adrenaline is suppressing ACTH secretions. Increase adrenaline is giving negative feedback, is suppressing ACTH levels.
Very good, because cortisol is actually released from the adrenal gland. So when there is too much amount of cortisol which is releasing from the adrenal gland, it is and act on the pituitary, and it will ask pituitary to stop secrete ACTH. So thereby overall you will see decreased ACTH level. So whenever there is the pathophysiology, there is some dysfunctioning in the adrenal gland, you will see that cortisol is releasing because of adrenal gland problem, because of tumor inside the adrenal gland. Definitely that too much amount of cortisol is going to act on the pituitary. It will ask pituitary to stop producing ACTH. So low ACTH means that there must be some pathology inside the adrenal gland, most likely a tumor. But if the ACTH level is elevated, the source could be from pituitary. Maybe there is some problem in the pituitary. Pituitary is secreting too much amount of ACTH and pituitary is not listening to the cortisol at all. And there will be an inhibition of the negative feedback. Even though cortisol is too much rising, but pituitary is not going to bother. Pituitary keeps on secreting because there is a tumor inside the pituitary which is keep on releasing the ACTH. So that's why the overall ACTH level is high, despite of the fact that cortisol is high, but ACTH is not stopping because the pathology is inside the pituitary gland and pituitary gland is not listening at all. Or maybe there is some other thing. Maybe there are some other ectopic foci, like in the lung cancer, some lung cancer tissues, they are producing similar thing just like ACTH. So whether the cortisol is rising, but that thing is actually just represent or mimic like ACTH, and you will find that there will be increased amount of ACTH. So once the ACTH level is elevated and does not suppress with high dose dexamethasone, dexamethasone is just like cortisol. So if you're just giving it from outside the body, the ACTH should be stopped. Then we can say, okay, it's adrenal pathology. But despite of giving this dexamethasone from outside the body, this ACTH is not stopping, the levels keep on rising, it means that you have to scan the brain. There is something inside the brain, there's something inside the pituitary. Sometimes the pituitary tumor are very small, even you cannot find them on MRI. What you're going to do then? Then you have to check sampling, petrosal sinus sampling, because why? This ACTH is going to release and it's going to stay in this sinuses area, this ACTH hormone. So maybe when you do MRI scan, you will not able to detect that small pituitary tumor. But when you do this petrosal sampling, you will get to know, okay, ACTH is very high in pituitary, in this petrosal sinuses. It means that ACTH is releasing from the pituitary. That's why it keep on storing in petrosal sinuses. Dr. Hunay is having too much problem in connecting. So sad. All right. So, but always remember, you have to check. First of all, always try to do this 24-hour urinary cortisol testing. There you will get to know, okay, cortisol is raised. Then you will try to give dexamethasone from outside the body and you will see whether the ACTH is decreased or not decreased. If by giving this dexamethasone from outside the body and ACTH is decreased, it means that pathology is inside the adrenal gland. But if you are giving dexamethasone and ACTH is still keep on rising, you have to always think for scanning of the brain. When you do the scanning, when you do the MRI of the brain and you find pituitary tumor, well and good, treat it. If you are not able to find, just don't stop there. You have to check petrosal sinus sampling because sometimes pituitary tumor are very small. You cannot find them on MRI. So you have to go for petrosal venous sampling sinuses. Okay, so it's just all over the summary. Like the patient is going to say, I feel weak, I feel tired, I notice hair growth on my face and strange marks on my stomach. These are all the presentation. What you will do, you will go for either you have two options. You will go for 1 milligram dexamethasone suppression test right away, but that is not very specific. Just leave it. Try to go for this 24-hour urinary cortisol. Once you see the ACTH is high, it means that there is something inside the brain. You have to rule out that there must be reason in the not in the adrenal gland, there must be some outside. But if there is low ACTH, it means that adrenal glands are responsible. So you have to exclude them. So it's dependent, it should be ACTH dependent or independent. We have to rule out on the basis of these tests. Okay, so we will just see the, so treatment, of course, if there is tumor inside the adrenal gland, you are going to treat that. If there is tumor inside the pituitary, you have to treat that. If the patient is having history of lung cancer, you have to evaluate that. So the treatment will be depend on where exactly the lesion is there. So it's not very specific. It depends. So let's solve our first question based on this. So first question says, a 40-year-old man presents to the doctor with a history of central weight gain. We have to look for this sign and symptoms, especially change in facial appearance, poor libido, easy bruising, back pain. Examination reveals pigmentation of the skin, striae, their buffalo hump, very important point here, edema, proximal muscle wasting, and elevated blood pressure. Hypertension, of course, for this increased amount of cortisol will cause increase in blood pressure. So which of the following is the most likely diagnosis? So very obvious, based on the presentation of the patient, you are going to choose here based on buffalo hump, based on hypertension, based on striae on the skin, based on bruising, based on poor libido, based on facial appearance, change in facial appearance. You will go for especially blood pressure, hypertension. So what should be your answer?
Cushing's disease.
You will go for Cushing disease. And Cushing disease, especially now, again, it's very important to realize when we go for the testing, then only we can come to know whether it's a pituitary cause or it's adrenal cause. Then the next question, a 32-year-old woman comes with...
Please explain this B, C, and D. Why not adrenal adenomas, adrenal carcinomas, and pituitary adenomas?
See, this adrenal adenomas, adrenal carcinoma, how you can say adrenal at this point of time, when you even have tests in front of you, you don't know whether the cause is adrenal or whether the cause is pituitary. So right now you can just say Cushing disease. Right now you can just say there's increased level of cortisol based on the symptom. But once you have things in your hand, like they say, okay, the cause is adrenal then, or you will find something on MRI. then you can say adrenal for saying adrenal adenoma, there should be adenoma inside the adrenal gland. But how can you? Yes, yes.
Cushing disease will be our clinical diagnosis.
Yes.
And adenomas, carcinomas,
And pituitary, that will be a definitive diagnosis.
Where the cause.
Yes, exactly. And those should be dependent on the diagnostic testing. So whatever the result of the diagnostic test, then only you can say, okay, this is a definitive diagnosis of this patient. Right now, it's just a Cushing based on the clinical presentation. Okay. The next question says, a 32-year-old woman comes to the physician because of weight gain.
I was expecting we will do this at the last after cortisolism. And I was reading this. And that's why I joined the late. But you have already done this.
It's okay. We'll just go over the recording now if you want.
Okay.
Yeah. Okay. So a 32-year-old woman comes to the physician because of weight gain, generalized weakness, and irregular menstrual cycle for the past 16 months. She began having symptoms of insomnia and depression 10 months ago. More recently, she has been having difficulty rising from a chair. She has a 2-year history of hypertension. Current medication includes citalopram and hydrochlorothiazide. She is 5 feet 6 inches tall and weighs 100 kilograms. BMI 36 too much. Her pulse is 92, respiration 18. Blood pressure is okay. She appears tired and has a full plethoric face and central obesity. Examination of the skin shows vivacious linear striations on her lower abdomen, and lab results showed increased cortisol. So increased cortisol. Cortisolism is there. And increased ACTH. So think about this one, increase cortisol and increase ACTH. Which of the following is the most appropriate next step in evaluation? What you are going to do next? So what do you think? The patient is having hypercortisolism and ACTH is also increased. If ACTH is decreased, we can think about adrenal gland, right? But what we will do next in order to do this thing, in order to confirm this thing? Either you go for
Meyer ACTH levels inferior petrosal sinus.
No, no dear, no dear. After MRI, always think for this petrosal
MRI
sinus.
of the head first, then.
But before MRI, you also have one thing. You can give this high dose dexamethasone. You should give dexamethasone outside from the body, because dexamethasone is just like cortisol. And if by giving high dose dexamethasone from outside the body, and if you see the pituitary is suppressed, then it's okay. The pathology is in the adrenal gland. If despite of giving high dose of cortisol outside from the body, just like high dose dexamethasone, the pituitary is not stopped working, ACTH is still high, then you should go for MRI. If you don't find anything on MRI, go for petrosal venous sampling.
Okay, then
are you getting me? Yes.
Right,
so it should be high dose dexamethasone.
If there is, it's from the adrenal, then it will be suppressed.
Yes. No. Yes. See, you will decide. You will decide on the basis of high dose dexamethasone test. If by giving high dose dexamethasone, if by giving high dose cortisol outside the body, the ACTH is low, think about adrenal cause. Because now the ACTH is low, pituitary is not involved. There must be something inside the adrenal gland, or there must be something in the lung, right? That, like in the case of lung cancer. But if by giving high dose dexamethasone still ACTH is very high, then forget about adrenal gland. Think about only pituitary, because pituitary is the one from where the ACTH is releasing. Are you getting my point?
Yes.
So by giving dexamethasone outside from the body, if ACTH is low, think about adrenal only, because now ACTH is low, it means pituitary is working fine, because there's a negative feedback. Cortisol, high amount of cortisol outside the body you're giving, that high amount of cortisol will going to act on pituitary. If pituitary is working normal, it should suppress ACTH. That's a negative feedback, right? High level of cortisol will act on pituitary and ask pituitary to stop secrete ACTH. Now there's too much cortisol, no need to secrete more ACTH, right? But if pituitary is not working fine, then there will be too much amount of ACTH. It means that you have to think that pathology is inside the pituitary. Then you will go for MRI. You won't find anything on MRI, go for petrosal venous sampling. Okay, so here the answer should be high dose. Okay. For the next one, we should go for the next topic first. So we'll do this central diabetes insipidus. Diabetes insipidus, we should actually cover both nephrogenic and central, but recall is mostly based on central. So we'll go for this one, 622. So actually this diabetes insipidus is what? It's actually, it's where we will see too much amount of sodium inside the blood. So why? This is why, because in diabetes insipidus, there will be, it leads to high volume water loss from insufficient or ineffective antidiuretic hormone. So it's actually the defect in the antidiuretic hormone. Maybe there is too much, less quantity of ADH, or maybe ineffective, whatever the ADH is secreting, that is not appropriate. So maybe ineffective antidiuretic hormone or insufficient antidiuretic hormone. And what do we mean by antidiuretic? Diuresis means there will be too much amount of water in urine, right? That is diuresis. Antidiuretic means that it's going to inhibit the phenomena of diuresis, and there will be too much retention of water inside the body, right? So in diabetes insipidus, there will be high volume water loss. And why this is high volume water loss? Because there is no one to stop diuresis there, because ADH is not working properly. If ADH is working properly, it's going to, what it's going to do? It's going to inhibit the flow of water outside the body. It's going to do antidiuresis. It's going to stop water. It's going to retain water inside the body. But if there is no ADH, or whether the ADH is there, but it's not sufficient enough or inefficient, what will happen? There will be too much amount of water which is going to be lost from person's body, and we will say there will be high volume water loss. So whenever there is high volume water loss because of the ADH improper functioning, we will say this is diabetes insipidus, right? Now, any brain disorder, any CNS involves brain and spinal cord both. So anything related to stroke, anything related to tumor inside the brain, spinal cord tumor, trauma, or history or over the spinal cord, or trauma to the brain, or hypoxia or infection inside the brain and spinal cord, anything in the CNS, anything in the brain spinal cord can damage the production of antidiuretic hormone, because again, this ADH is actually secreted from hypothalamus. Or storage in the, we know very well this ADH and the other one, oxytocin, they are actually produced inside the hypothalamus, but they are going to be stored in the posterior pituitary. Posterior pituitary is the one which is not actually forming these hormones. They are the hormones which are formed inside the hypothalamus, and they are actually going to be stored in the posterior pituitary. And once they want to action, they will release from the posterior pituitary. Other than that, we have this ACTH and thyroid releasing hormone and prolactin and all that's somatostatin. They are actually released from the anterior pituitary. But the posterior pituitary is the one which is not actually forming these oxytocin and antidiuretic hormone. The posterior pituitary is actually storing them. Who is the one who is producing this one? Hypothalamus is the one. So when we say the pituitary is the master gland, we should not say pituitary is the master gland. We should say hypothalamus is the master endocrine gland, because hypothalamus is the one who always secretes some inhibitory and excitatory hormones, and that is going to act on the pituitary and ask pituitary to secrete, a particular hormone. But anyhow, so here we will just memorize this one, that any defect in the brain and the spinal cord, it can cause ADH dysfunctioning. When it comes to nephrogenic DI, so this is actually the central diabetes, central diabetes insipidus, that is related to the brain and the spinal cord. Now, when we say nephrogenic diabetes insipidus, it means that there will be dysfunctioning of the ADH, but on which level? On the collecting duct of the kidney. There will be loss of ADH effect. Antidiuretic hormone is there, but don't know why it's not properly functioning, and it's not properly functioning on where it has to function. It has to function on collecting duct of the kidney. So it's actually not working properly on the kidney receptors, and there is much less common. It's very less common. It's caused by lithium, some of the drug, maybe there is CKD problem, chronic kidney disease, maybe because of some electrolyte disbalance. It's not actually working properly on the receptors where it should work properly. So we will say it's a nephrogenic. So it's pathology related to the brain. We will say it's central diabetes insipidus, and where it has to function on the kidney, if because of any kidney pathology, the functioning is not there, because it's not going to bind on the receptor on the kidney and not performing its function, we will say it's a nephrogenic diabetes. So for our exam point of view, you should know again the symptoms and how we are going to diagnose this one. So for this one, we will see diabetes insipidus. Of course, if there is too much amount of water. Now, what is the whole mechanism? When water is excreted from the body, it's actually not excreting from the it's excreted from the body, but as a result, as you can say, like one is going out and someone has to be in to control it, there will be too much amount of sodium inside the body. You will always see hypernatremia. Why there is hypernatremia? Because that's a natural body mechanism. When there is too much amount of water is going to be lost in the body, the sodium has to be retained inside, so that when one sodium goes, it will take 10 molecule of water inside. That is a protective mechanism of our body. So whenever there is too much amount of water is going to lost in the body, the working mechanism of our body should do what? It should retain sodium. Why it's retaining sodium? Because it knows very well when sodium goes inside or when sodium remains inside the blood, it will take 10 molecules of water inside. So that is the protective mechanism. That's why always in diabetes insipidus cases, we are always seeing hypernatremia as a defensive mechanism. So because of too much amount of course, when there is too much amount of the sodium inside the body, it will cause confusion, it will cause disorientation. So you will see the patient is lethargic, the patient must be having seizures or may present with seizures. If uncorrected, severe hypernatremia can cause coma and irreversible brain damage also. That's a body's metabolism, body's protective defense mechanism. When there is loss of amount of water outside the body, there has to be some mineral retention, and that is sodium, because body knows, our system knows that when sodium retains, it will take water inside. So but if too much amount of sodium, it will cause these symptoms. So if the patient is presenting with all these symptoms, think about diabetes insipidus. So what you will see there will be lots amount of water, especially polyuria, very high urine volume. Frequency just mean increase attempted voiding. The volume is urinary frequency might be very small, such as now it's very important. You should see that it should be high urine volume. Polyuria should be there. Osmolality will be decreased. There will be very thin urine, just like watery urine. So it should be polyuria. Not like in the cases where there is an infection and you see, increased urgency or increased frequency. It's not about increased frequency. It's about increased volume of water, which is actually lost because of improper functioning of the antidiuretic hormone. So how we are going to diagnose these patients? High serum sodium is nearly equivalent to hyperosmolality, since the majority of osmolality is sodium. Fluid losses from the skin, kidneys, or stool generally lead. So this is the same pathophysiology we are talking about. Now, decreased urine volume, higher urine volume in diabetes. So this always remember, we will see there will be lots of amount of volume. Polyuria should be there. And increased urine osmolality, decreased urine osmolality in diabetes insipidus. Now, what they are discussing here? Increased urine volume despite dehydration and hyperosmolality of the blood suggests diabetes insipidus. No doubt the patient is dehydrated because ADH is not working properly. Too much amount of water is lost. The patient is getting dehydrated, and despite of dehydration, still the patient is showing too much amount of fluid, too much amount of urine. It means that it's showing that, suggesting that the patient is having diabetes insipidus. So in urine, you will see less amount of sodium. Sodium will be retained more inside the blood. Hypernatremia will be there. So if hypernatremia is there, you have to check urine osmolarity, whether the urine is viscous or not. You have to see. So if the urine osmolarity is less than 800 or more than 800, we have to think about it. So if it's less than 800, there must be some cause which is related to the kidney. And if it's more than 800, we have to think about other losses, maybe GI loss, maybe insensible water loss, that is in the form of sweating. Maybe the patient is taking too much amount of sodium, but we are not bothered about this part. Why? Because we have to diagnose diabetes insipidus. So we'll take this one. The osmolarity will be decreased. And if it's decreased, we have to think about always diabetes insipidus. We will get to know if there is any pathology in the brain we can rule out. We will say it's a central, or if only the pathology remains inside the kidney, we will think about nephrogenic diabetes. But if it's an other cause, because the kidney is excreting too much amount of water, but not because of diabetes insipidus, maybe because of osmotic diuresis, we have to think about this diabetic ketoacidosis and too much amount of mannitol intake in urea. But again, we are not bothered about this one because we are mainly focused on the real cause of renal water loss here, which is the diabetes insipidus, which is actually the dysfunctioning of the ADH. ADH is not properly working, and because of that, there will be too much amount of urine, too much amount of water is going to be secreted in urine. But as a result, defensive mechanism, we will see large amount of sodium will be retained inside the blood. There will be hyponatremia, and that hyponatremia is going to cause lethargy and all those CNS problems.
Urine osmolality will decrease and blood osmolality will increase.
Yes, it's vice versa. Yes. Okay. So that's the same thing again. That's the main, if we are going to compare the main differences between central diabetes and nephrogenic diabetes, so almost always same. But of course, if you are going to give ADH from outside, say for example, so if there is really a pathology on kidney, of course kidney will not work because there's pathology inside the kidney. If you are giving ADH from the brain and if you are giving ADH outside the body, it will make no difference because the pathology is inside the kidney. Say maybe for example in case of CKD, so it doesn't matter you are going to give ADH from outside or the brain is producing ADH, hypothalamus is producing ADH, but kidney is not going to work at all. But if it's a case of central diabetes, of course, when you are going to give ADH from outside, it will work. So response to ADH will be there if there is central diabetes, because central means brain is not, hypothalamus is not performing or is not releasing ADH. So if you give ADH from outside, the body should respond good because now the body is receiving ADH from outside. But if the pathology is inside the kidney, means it's nephrogenic diabetes insipidus, no matter how much amount of ADH you are going to give from outside the body, what will happen? Kidney will not work, right? So we will see there will be no response in case of nephrogenic diabetes insipidus. So we have to think about what we can do. If it's a CDI, of course, you are going to give from outside the body. If it's a central diabetes insipidus, you will replace ADH. But if it's a nephrogenic diabetes, you have no option. You have to look for the kidney pathology. You have to go for the treatment for kidney pathology. Maybe some drug who is causing this problem, you have to stop that drug. Say, for example, lithium. If it's causing, you have to stop that. So, or correct a mineral metabolism, whatever electrolyte disturbance is there, you have to correct it. Whatever kidney pathology is there, we have to treat that first. So if we just go to the questions, then we will see. A 30-year-old man presents with a history of increased urine output. Urine output is increased. They are not saying urine urgency is there or frequency is there. No, they are mainly focused on output, like volume of urine is high, especially during the night, and increased thirst for the past 2 months. Of course, if that's again a body defensive mechanism. If it is too much amount of urine output, there will be too much thirst because hypothalamus is functioning properly. Now, water deprivation test. Urine volume stays high and urine osmolality stays low despite various urine production, sharp decrease in urine volume and increase in osmolality in response to ADH administration. Again, the body is responding with ADH. That is called water deprivation test. You are going to give ADH from outside the body, and if your body responds, which of the following is the most likely diagnosis? What do you think? Which diabetes insipidus is going to respond when you give ADH from outside the body?
Central diabetes.
Exactly, central, because there must be pathology in the hypothalamus. That's why when you are giving from outside the body is working properly, or the response is there. So it should be central diabetes insipidus. Okay. Next topic, we have to go for thyrotoxicosis. Thyrotoxicosis is not very much in detail in MTB, so I'll just go to this canvas. So again, it's just like hypercortisolism, like increased amount of cortisol, here increased amount of thyroid hormones we will see. So, but there is increased amount of, so the term hyperthyroidism and the term thyrotoxicosis, they are interchangeable, just like Cushing disease and just like hypercortisolism. So you can say whether it's hyperthyroidism, there is thyrotoxicosis. There will be too much amount of thyroid hormones. So thyrotoxicosis refers to symptoms caused by excessive circulation of thyroid hormones, and it is typically caused by thyroid gland hyperactivity. So there will be too much activity over the thyroid gland. Thyroid gland is stimulated so much, or there is some pathology that's causing increased amount of T3 and T4. So the most common cause which we usually see in case of hyperthyroidism is Graves' disease. That's the most common one. It's autoimmune especially. Or there may be toxic multinodular goiter, maybe toxic adenoma. So of course there is tumor inside the thyroid gland. That tumor is actually producing too much amount of T3 and T4. That makes sense. So if we go to this, especially here, Here in this question, again, the presentation is very important, and most likely thyrotoxicosis, you will find always those questions which are asking about the testing, like TSH, what should be the value of the TSH? TSH should be high or low, and what about the T3 and T4? So always consider thyrotoxicosis or thyroid storm. There will be too much amount of T3 and T4, and of course, TSH will be low. So always remember the amount of TSH should be low. Whatever the question is there, TSH should be low and T3, T4 is high. Then only think about this thyrotoxicosis. So if we see the clinical features of these patients, they will just produce the features of they will just present with the features of hyperthyroidism. Say, for example, there will be too much heat intolerance, excessive sweating. You can see the weight loss changes in your patient. There will be less appetite. There will be the patient will get tired or feet wheel. There will be too much frequent bowel movement. All the symptoms of hyperthyroidism, and hyperthyroidism features almost all the same in all types of hyperthyroidism. In the eyes, you will see especially this Graves ophthalmopathy, where there is exophthalmos, there is edema of the periorbital tissues. That's a special finding in your patients. Goiter will be there. If we are talking about cardiovascular, the patient may have tachycardia, must be presenting with hypertension. Systolic pressure will be increased. You will see, because hypertension most likely the systolic pressure is going to be rise there. Diastolic pressure is decreased due to decreased peripheral vascular resistance. That is a separate thing. It's again, it's a defense mechanism of our body. When there is too much cardiac output, if we increase the peripheral resistance, the cardiac output will be decreased. That is a defense mechanism. So anyhow, you will see hypertension in these patients. If we are talking about this musculoskeletal, the patient must be presenting with the spine tremors. There will be myopathic disorders. There will be proximal muscles involvement will be there. So you will see some musculoskeletal changes in long-term thyrotoxicotic patients. Endocrinology, we will see in females, if we are considering, there will be oligomenorrhea, there will be infertility disorders and ovulatory disorders. We will see some dysfunctional uterine bleeding. Male, if we are considering, again, hyperthyroid features in male will be erectile dysfunction, there will be infertility, domestic can be there, decreased libido. These are all the features of hyperthyroidism. So in all diseases of hyperthyroidism, the features are almost all the same. You will not get any difference here. But diagnostic, we have to consider more here in these patients. So once they ask you any hyperthyroidism or especially thyrotoxicosis, always remember that we will see increased T3 and T4, and we will see decreased TSH. So initial evaluation, perform clinical assessment and increased thyroid function test. Of course, we will do this one. And of course, if TFT is normal, you have to think about any other disease. You will see this one, there is nothing significant. But if it's a grave disease, because it's an autoimmune disease, so it's specific. So if they are specifically saying that antibodies are present, think about grave disease. If they are saying that if nothing related to this antibodies, think about only this hyperthyroidism, only if the prominent on physical examination, if you have seen this nodule or goiter, straight away the diagnosis will be there. So if you just look over this picture, I want to show you one picture here where you can just differentiate this one. So let me pull out that picture. We have this diagnosis of hyperthyroidism. I hope you can see, you are able to see this picture. So I will share this one with you. So see, if there is a suspected hyperthyroidism, you have to see this thyroid function test. So if TSH is increased, and if you also see if TSH is normal or increased, and if T3 and T4 are also increased, so there must be some other causes rather than thyroid. There must be some pituitary or something else, because again here you are saying normal or increased TSH, because TSH is released from the pituitary. So if there is pituitary adenoma, if there is tumor inside the pituitary keep on releasing this TSH. No doubt you have T3 and T4, high levels of T3 and T4, but those high levels of T3 and T4 will not go and give negative feedback on the pituitary, because there's a tumor inside the pituitary. But if T3 and T4 is high and TSH is decreased, that means, of course, it's a thyroid problem. We can say it's a thyroid. And if the TSH is decreased and T3, T4, it's okay. That levels are not too much, but TSH is decreased. Thyroid is not functioning properly. This TSH is actually not going to work on this thyroid hormone. We can, and we will see the features, clinical presentation of hyperthyroidism. We can say it's subclinical one. In subclinical one, the TSH will be decreased, but T3, T4 are not very much increased. So you can say it's a hyperthyroid patient, but it's subclinical. And of course, if nothing is increased, no TSH and no T3 input, then we are not suspecting hyperthyroidism at all. And this one, if antibodies are there, we have to say it's a grave disease. And if you can see, find the nodule, you can say it's a goiter. And this antibodies again, if we check these antibodies, if antibodies are present again, Hashimoto's, it's again autoimmune disease, we can easily differentiate that. If there is no antibodies thing, only the inflammation is there, we will think about thyroiditis, we will think about any exposure outside the body. So there may be. So it's very obvious that we have to only check for TSH and T3, T4 level, and we will see based on the type, which type is there. Maybe we can easily find goiter, we can easily find nodule, or if antibodies are there, we can easily say, okay, it's a Hashimoto's or it's a grave disease based on the antibodies. So if we just go over the question. Here the question says a 60-year-old patient complains of irritability. So we'll look for the symptom of the patient. That's very important just in order to make a diagnosis. Heat intolerance is there. Recent onset of heart palpitation. The neck examination is normal. See, the neck examination is normal. Forget about nodular goiter. Forget about this one, any nodule, toxic nodule. Test result normal values. Thyroid stimulating hormone 0.1. Normal is 0.4 to 5.0. So TSH is low. TSH is low. Thyroxine, see, thyroxine 30.4. Normal is 8.5 to 15.2. It's very high. T4 is high. T3 is again high, 9.5. Normal is 3.5 to 6.5. So T3, T4 raised, TSH low. On neck, there is nothing significant. So what you're going to say? What is the most likely diagnosis? What do you think?
Thyrotoxicosis.
Of course, it's thyrotoxicosis. You cannot say sick euthyroid. It's not a euthyroid. Euthyroid means everything is normal. There is no normal on investigation. Primary hypothyroidism. If TSH is low, how can we say it's a hyperthyroidism? T3 toxicosis, only T3 toxicosis, T4 will not be rise. So here the T4 is highly elevated. So we'll say it's thyrotoxicosis based on the investigations. Okay. A patient, okay, this is hypothyroidism. Actually, we'll go for hypothyroidism first. 102. Okay, for hypothyroidism, all the features are reversed, right? So say, for example, in hyper, if you're having too much tachycardia, here we will see bradycardia. If diarrhea is there, hypertrophication and hyperthyroidism, we will see constipation here. All the symptoms are reversed, right? Because now there is too much amount of TSH, but less T3 and T4. Weight loss were there in the hyperthyroidism, now we will see weight gain here. So all are opposite. Similarly, heat intolerance, here we will see cold intolerance. Okay. Now, what is the main etiology of this hypothyroidism? So, most from failure of thyroid gland. Thyroid gland is not working properly. TSH is releasing normal amount from the pituitary gland. Pituitary is perfectly fine. Pituitary is doing his work, but it's actually the thyroid who is not releasing T3 and T4. So here we can say mostly of thyroid gland from burnout, Hashimoto's thyroiditis. This is again an autoimmune disorder. Acute phase is really perceived dietary deficiency of iodine. Maybe iodine is not there in order to make this T3 and T4. Maybe some drugs are there that are actually going to inhibit the mechanism of this iodine from iodine and whole metabolism of T3 and T4. So what to look for? In hypo, everything will be slow except this menstrual flow. That of course is going to be increased here in these patients. So diagnostic, again, we will see this best initial test will be thyroid. In order to go for the testing, we'll go check for the TSH. TSH should be raised. Again, TSH is raised. And if the TSH level is suppressed, measure. Now we have to, it's not only about TSH. We have to look for the TSH and we have to look for the T3 and T4 as well. Here it should be, in case of hypothyroidism, the T3 and T4 should be less. But just in case, if all the features are of hypo, but you will see the TSH level is suppressed, then you have to go for and check for T4. Maybe T4 is very high, T3 is normal, and that T4 is actually free T4. That is going to act on work on pituitary and ask pituitary to stop releasing this TSH. So sometimes the patient is hypothyroid, but isolated level of increased T4 is there that is going to inhibit this TSH. So again, in these patients, we will see that TSH is low, T4 is high, but all the symptoms are suggestive of hypothyroidism. That's very rare, of course, but we can see this picture also. What you're going to do, you just give T3 and T4 outside the body. We will just give synthroid. We will replace the thyroxine. Okay, so features are all this one. This is a hyper. Now we'll just go and solve this question. Now, patient with hypothyroidism. Now, here we have the full diagnosis of our patient. It's hypothyroid patient. On 0.025 milligram of levothyroxine, complains of fatigue, cold intolerance, and weight gain. Now, he's already using this levothyroxine. He's already using this synthroid, this especially T4. But he's still having these symptoms. Blood pressure is this is okay. Heart rate is slow. Bradycardia is showing normal value TSH. Now once you go for the testing, you see TSH 19.9. Although he is on thyroxine, but his TSH is still very high. It should be in between 0.4 to 6.5, or normally it should be it's 2.5. It's showing 19.9 despite on being thyroxine. What you're going to do next? Any clue what you're going to do next? In clinical practice, what we will do, what we usually do, we increase the dose, because this dose maybe is not complying to the patient is not responding on this dose. So you have to increase the dose, and you have to repeat TSH level whether the increased dose is working properly or not working properly. So the 6 weeks evidence actually I have just seen here. I wanted to show you this one. Yeah, that's the point. So I have searched so many literatures, and I found 4-5 good literatures where it's mentioned clearly that if you are going to increase the dose of thyroxine, you should repeat TSH level in 6 weeks. So this is British Columbia guideline. It says that frequent repeat testing is not indicated, but TSH may be repeated after at least 6 weeks following a change in thyroid hormone replacement dose or in the patient's clinical status. So here, the status of the patient is showing also the patient is not responding on the given dose. And here also, we see that the TSH is very high, 19.9, and we have to increase the amount of levothyroxine. So we will just increase the dose of the medicine, and we will follow TSH after 6 weeks, just in order to check whether our prescribed medication is now working properly or not. If still the patient is not responding, we usually have to increase more. So it's a clear evidence here, 6 weeks. So we will go here and check this one. Increase levothyroxine and check TSH in 6 weeks.
Dr. Hira, can you share the British?
Yeah. This British Columbia guideline, I will show you this in PDF form. Don't worry. This one, huh? This one you want. I will show you this one.
Okay, thanks.
Okay. The next question. For the next question, we have to go for the theory first. Then we have this beta thalassemia. Okay, beta thalassemia, again, it's not very much in detail. So I will just want to show you from Ambus. Maybe it's open already. Yeah. Okay, so for thalassemia, again, the questions are usually the diagnostic testing based on the genetic testing, because we know very well it's a genetic mutation disease where we'll see some globin chain deficiencies, especially 2 or 4, or maybe single allele is deficient. So based on the on those things, and based on the presence of hemoglobin F, and based on the presence of hemoglobin A2, which is the adult hemoglobin, we'll say it's a disorder. So it's actually a genetic disorder. So mostly questions are linked to how you can say it's beta thalassemia, how you will say it's alpha thalassemia, and what will be the best initial test and most accurate test for this one. So here, if we can see, I want to show you here, especially in case of this one. Diagnostic here, it will be very important. Of course, it's a blood disorder where you'll see too much, chances of hemolysis is there. You can rarely see, sometimes there will be too much splenomegaly. Splenomegaly is a massive finding here sometimes. But we will look for especially the types of thalassemia here. So most likely you will see hepatosplenomegaly, of course, in these patients, because here there will be too much lysis of blood. The blood is not properly functioning. The blood is not properly formed because of the defective chain, especially in globin chain, which is the main thing to form hemoglobin. Hemoglobin is not properly working, or whether the hemoglobin is already formed, but that is actually the malformed, and spleen is going to capture all those things, and spleen is getting bigger and bigger, and liver also detoxified at once. The liver is also going to get, increase in, or there will be hyperplasia in the liver as well. So you will see hepatomegaly as well. You will see splenomegaly as well.
Yes, properly.
Sorry?
I can't see the screen properly.
You cannot see the screen properly?
Yeah.
Okay. Do you want me to share again? 1 minute.
Yeah.
Okay, now can you see?
No, I still can't see it.
Okay, anyone else is having the same problem?
We can see very clearly.
Yeah, doctor, I can see.
Or maybe you can just
Maybe she
leave
has
the session
internet problem.
and join session again. Yeah. So if you could just leave the session and join again, maybe there's some network problem. Yeah. Okay, so if you're considering this beta thalassemia, what are the clinical features? How the patient is going to present with you if she or he is beta thalassemia? Maybe I should show you the epidemiology first, etiology first. So see, in beta thalassemia, usually due to point mutations in promoter sequence or this is especially splicing sites. So it's again it's a genetic mutation. It's a point mutation. Here we see beta globin locus, short arm of chromosome 11. There is going to be a defected gene here. Okay, Ashna is here. So it's actually the point mutation here on which chromosome? Chromosome number 11. If you want to memorize this one, it's okay, but it's not very significant to memorize here at this point of time. Alpha thalassemia, usually due to deletion of at least 1 out of 4 existing alleles. So 4 alleles there. If only 1 is missing, we can say it's alpha thalassemia. The alpha globin gene cluster is located on chromosome 16. So whenever there is something related to 16, think about alpha. Related to 11, think about beta. And inheritance pattern is autosomal recessive, of course. If one parent is absolutely normal, other is having carrier, the babies are going to be carrier, but babies morphologically will be perfectly fine. So most of the time, not in our setup, but internationally, especially before marriages, they usually undergo for this testing. And we will solve one recall based on this one as well. When the patient is before marriage, wants to consult about, and he's a carrier, and he doesn't know, because once there's beta thalassemia minor. Beta thalassemia actually has 2 types. Beta thalassemia minor, 3 types actually: minor, intermediate, and major. Major is the one which cannot be, which cannot live the life normally. He has to undergo multiple transfusions, maybe every week, maybe twice weekly. That person is not normal at all. Beta thalassemia patient, sometime, here and there he's having some problems. So you can easily say, okay, this is beta thalassemia, because the whole life he is suffering. But beta thalassemia minor is the one which is very tricky one, because beta thalassemia minor they are very, they are very inert, they are asymptomatic. You can never get to know that the patient is minor until and unless you go for the electrophoresis and you check whether really the patient is having something, or like hemoglobin A2 in those patients should be more than 3.5. That's a very in normal routine practice and clinical practice. When a patient comes to you, he's perfectly normal, he just want to know, he just want to ask that I'm going to get married, I just wanted to see whether I'm having this minor trait or not, or whether I'm having anything which is going to be create a problem if my wife is also having this minor trait, because it's very common internationally. So in those patients, what we usually do, we just go for electrophoresis and we check H hemoglobin A2. If A2 is more than 3.5, we just say he's a minor case. So it's very clear-cut diagnosis. You can easily say any person who is having hemoglobin A2 more than 3.5%, and everything other is normal, absolutely normal. Sometimes he's having slight hemoglobin, less hemoglobin, slight MCV slightly low. All the blood markers are slightly low, but those markers are on that level where the patient is asymptomatic. Patient is not presenting any symptom. Always think about beta thalassemia minor. The beta thalassemia minor is very important because it's very tricky on diagnosis. The patient is absolutely normal, or some blood lines are low, but low at the point where the patient is asymptomatic, actually not symptomatic at all. Only one defective allele in beta thalassemia minor. Major, of course, there will be 2 defective alleles are there, and the patient is experiencing lots of problems. And if the patient is having sickle cell dominancy is there, we can say sickle cell beta thalassemia. And these sickle cell thalassemia patients, they are actually, they are very hard to survive, because these sickle cells are going to entrap in the spleen, and we have to change them. Nothing in that, we have to, we will ask for the bone marrow transplantation. We don't have any other choice. So other than that, it's okay. Now for alpha thalassemia, it's very obvious when we go for the electrophoresis, we see this alpha globin chains, and only one can be missing. And alpha thalassemia, again, they are not going to show any more any symptoms, but again we have to go for electrophoresis and we can easily rule out. So clinical features, of course, we'll go for the clinical features. So beta thalassemia, we will see minor, and intermediate will show no symptom. But in case of beta thalassemia major, you will see severe hemolytic anemia, you will see hepatosplenomegaly, there will be growth retardation, there will be skeletal deformities. So throughout the life, the patient is experiencing problem, or sometimes the patient is also experiencing this transient aplastic crisis also, which is superimposed due to infection. Superimposed infection of parvovirus B19. So whenever there is this virus is going to create a crisis inside the body of that particular patient who is having beta thalassemia major, and it is responsible for creating this transient aplastic crisis. Like bone marrow stopped working properly, bone marrow is not going to produce anything. That is the crisis. And why is that so? Because of the infection, superimposed infection. It's rare, but it's there. Sickle cell beta thalassemia, we have already seen this one, sickle associated with sickle disease. The RBCs are sickle shaped, are not normal at all, morphological disturbances there. Okay, so for alpha thalassemia, again, we already did this one. But see, the features are almost the same. In order to diagnose alpha thalassemia trait, you will go for electrophoresis. There will be normal RBC, there will be normal everything, but hemoglobin H, we will see the hemoglobin H will be there, or hemoglobin F also you can find in these patients. But and mostly these patients, you will see that on birth, at birth especially, they can present with anemia, they can present with jaundice, there will be hemolysis. Hemolysis is very common, of course. Why hemolysis is common? Because if RBCs are not in proper shape, they are going to be trapped inside the spleen, because spleen is the one whose function is to trap those RBCs which are not morphologically normal. So you will see hemolysis every time, and you will see splenomegaly. Splenomegaly is there. Liver also is going to detoxify that, and liver has to work also a lot in order to cope up with the spleen. Then liver will also be, showing this megaly. So we will see both of these conditions, hepatosplenomegaly. There is one syndrome here which is not, if you want, you can go over this one, hemoglobin Barth hydrophilialis syndrome, most severe variant of alpha thalassemia, where there is intrauterine ascites inside the mother when the baby is forming. Actually, during gestational age, you can see the ascites is there, the fetal abnormality. You are going to check on anomaly scan. There will be severe hepatosplenomegaly in the fetus. All the skeletal abnormalities are there. Soon after birth, shortly after birth, or you can also see inside the mother, you can also see. So we will say it's a hemoglobin Barth hydrophilialis. It's one of the type of alpha thalassemia. So the point is how you are going to manage these patients. Diagnosis is obviously very clear. Diagnosis, you will go for hemoglobin electrophoresis. You have no other option in spite of this one. And if you want to do, the most accurate test will be bone marrow biopsy. You can go for biopsy and you will see by yourself what kind of special histological cells are there. Okay, so we can check CBC also, of course. CBC, every blood line will be decreased because it's a dysfunction. But in case of minor beta thalassemia minor, you will not see too much amount of decrease. You will see hemoglobin is less. You will see our RBCs and all blood cell lines are decreased, but decrease at a level where the patient is not presenting with any symptoms. There will be no symptoms at all. Okay. So low ferritin suggests iron deficiency anemia, and patients should receive iron supplement. Again, symptomatic treatment. If you see the iron is ferritin is low, of course there will be iron deficiency anemia. That's why the RBCs are not morphologically normal. You will just give and prescribe this iron supplements, and suspect thalassemia if there is no significant response after 3 months of, despite of giving 3 months of treatment of iron, the patient hemoglobin is not rising, then you can just suspect, okay, maybe there is some thalassemic minor trait in this patient. That's why the patient hemoglobin is not responding despite of giving iron from outside. So hemoglobin electrophoresis will be the definitive diagnosis. Now, this is important here. If you want to diagnose alpha thalassemia minor, intermediate, and beta thalassemia minor and all that. So what we can see in alpha thalassemia, this mean corpuscular volume is normal or low. Everything you will see decreased. Hemoglobin A2 again, it can be normal, but in beta thalassemia, you will see HbA2 increase. And especially I'm telling you again and again because it's important to recall, hemoglobin A2, if it's more than 3.5%, always think about beta thalassemia. Beta thalassemia, if the patient is not, if the patient is asymptomatic, it should be beta thalassemia minor if HbA2 is raised more than 3.5%. Okay, so it's written here, beta thalassemia minor should be strongly suspected if hemoglobin A2 is more than 3.5%. It can be any value, but if it's more than 3.5%, always think about beta thalassemia minor. So how you're going to manage these patients? First of all, if minor is there, nothing you can do. You will just go for the counseling of the patient. You will just go and screen the other relatives. If the patient is going to get married, you have to screen the female also, just in order to see whether this minor trait can produce a major trait. Of course, it can be there. 4 out of 4 children, 1 can be major. Other can be carrier and particular normal. 1 exclusively normal, 2 carriers, and 1 thalassemic major. So what should be, you have to transfuse your patients with the blood, of course. Your target hemoglobin should be more than 9 to 10. So if hemoglobin 7, less than 7, always go for the transfusion. Other than that, you can give parenteral iron. But parenteral iron, honestly, in clinical setup, it's not working very fine with the thalassemic patient. Thalassemic patient, major patient, of course, you're going to go for the transfusion. And cutoff level is 7. Better don't give anything if it's more than 7. But if it's 7, less than 7, go for straight away transfusion of whole pixel volume. So if you just go for the questions here, 26-year-old woman presents for premarital counseling. Now here the question says premarital counseling. We have to look for the presentation of the patient. Patient is not having any symptom. She just went for premarital counseling. Test results, normal values, hemoglobin is 110, slightly low. Hematocrit, slightly low. MCV, low. Hemoglobin A2, 4.5%. Normal should be less than 3.5%. If it's more than 3.5%, A2 is more than 3.5%, always comes beta thalassemia minor in your mind. The patient is again asymptomatic, no symptoms. Sickling negative, there is no sickle cell trait also. So what do you think? Which of the following is the most likely diagnosis? What you're going to say?
Beta thalassemia minor.
Minor.
A beta thalassemia minor.
Minor.
Very clear based on investigation and clinical presentation of a patient. If it's beta thalassemia major, you will see everything here. Hemolysis, splenomegaly, the patient is not coping up with their life. After every twice a week, the patient is underwent this blood transfusion. Sickling crisis will be there. Then you will go for beta thalassemia major. Okay. The next one is aplastic anemia. Aplastic anemia, bone marrow is not functioning properly. Every blood cell line will be decreased. There will be pancytopenia. Everything will be low. So we'll just go for the handouts. 165. So aplastic anemia, there will be all blood cell line will be decreased. Pan means all will be low. Penia low, philia high. So pancytopenia, every cell count is low. Any infection or cancer can invade marrow, causing decrease. So it's actually the bone marrow dysfunctioning, where bone marrow is not working properly, and the all cells line will be decreased. The hyperplasia will be there, hyperfunctioning will be there. Other than that, what can be the causes? Of course, there may be radiation toxin that can lead to this dysfunctioning of the bone marrow. There may be some drugs that can act on it. There may be some autoimmune diseases. There may be some deficiencies like B12 and folate deficiency, some viruses that are responsible for decreasing the immunity of the patient. Say, for example, HIV virus. There may be thyroid inhibiting medications. Some medications are there that actually act on thyroid, but they are also act as an inhibitory substance for the bone marrow as well. For bone marrow receptor, they're just going to act as inhibitory what we can say, inhibitory effector, inhibitory substances or inhibitory modules, neuromodulators, just like act as a neuromodulators. So we will just we get to know most of the time radiations are the results of this aplastic anemia, or sometimes we don't know the etiology. We will say just etiopathy. Idiopathic, we don't know the etiology, or idiosyncratic. So what will be the finding of your patient? Your patient will be feeling fatigued, there will be infection, more chances of infection. Why? Because of the low white cell count, your body defenders, patient's body defender is low. Definitely the infection is going superstitious infections. Those who are actually not doing anything on a normal patient, but on these patients, they will be acting vigorously. Bleeding will be there because of thrombocytopenia, because every cell count is low. If hemoglobin is low, there will be no proper functioning of hemoglobin, oxygen will be low, there will be lungs problem. If there is decreased WBC count, again there will be infections problem. If there is platelet count low, there will be thrombocytopenia, there will be bleeding disorders, massive bleeding will be there. Most accurate test, you will go for the bone marrow biopsy, you will check by your own eyes histologically why the cell count are decreased, why they are not morphologically normal. Aplastic anemia is confirmed by excluding all causes of pancytopenia. So first evaluate other causes, and then this is actually a disease of exclusion. So you are going to exclude everything, other causes, and then finally you get to know, okay, this is aplastic anemia. Treatment, what you're going to do? Blood transfusion, of course, because of this one, there's too much hemolysis. Antibiotics for infection, platelets. If you are saying that there's too much bleeding, you have to transfuse normal amount of platelet from outside the body. So aplastic anemia act as autoimmune disorder. T cells attack patient's own marrow, own bone marrow, and there will be cyclosporine inhibit T cells, and thing brings to marrow back to life. So things bring the marrow back to life. So this cyclosporine, they're actually saying for this one, cyclosporine, what they're going to do, they are going to inhibit T cells. Inhibit T cells, just think about our own cells. They are actually acting on our own bone marrow, and they're producing autoimmune effect. Like our own things are going to destroy our own cells. See, T cells, they should not destroy, these are actually the T lymphocytes. They should not destroy our own protein, but if they are going to destroy our own protein of bone marrow, then what will happen? There will be suppression of the bone marrow. So what we can do, we can give this cyclosporine from outside the body. Cyclosporine is going to inhibit T cells. So now when they are inhibited, of course, there is no one will be there to inhibit bone marrow, and bone marrow will function properly. But it's only in that case where T cell is the reason. If T cell is not the reason, of course, cyclosporine is not going to work at all. So true aplastic anemia treated with allogenic bone marrow transplant, only thing we have, only last resort we have, we should transplant the bone marrow if young enough and matched. So you can just go for the bone marrow transplantation. When too old, like the patient is more than 50 years of age, there's the donor problem, everything is there, you will go for anti-thymocyte globulin and cyclosporine, because we are considering that T cells are responsible for killing the bone marrow. We have to give something that is going to inhibit T cells. So that is cyclosporine. Or if cyclosporine is not working, or patient is sensitive to cyclosporine, we can go for tacrolimus also. So always remember the cyclosporine, and especially bone marrow transplantation. So always look for the age of the patient. If the patient is young enough, the blood matches, because having this bone marrow transplantation, it's not only about the blood group should be matched. It's all about the HLA typing, the cell tissue should be matched. That's why we always recommended that if the elder brother is having this bone marrow problem, then the younger brother should have, give this or donate his or her bone marrow. Because if you're asking for the other one, the outsider party, that is not going to work, because sometimes, especially when you are transplanting kidney and all that, you can go outside the relative also can give. But here, especially in bone marrow transplantation, we have to have sibling bone marrow. Other than that, it will not going to work at all. There will be too much suppression and rejection. Okay, so if you just have a look on the question. So here it says a 26-year-old woman has become increasingly tired for the past 2 months, 26 years. During the past week, now she is feeling fatigued. During the past week, she has noted purple blotches on her skin. Purple blotches, maybe because of platelet dysfunctioning or low platelets. Bruises are there. On physical examination, them are petechial hemorrhages. So these are petechial hemorrhages on our trunk and extremities, and we know very well these petechial hemorrhages, these bruises are actually the superficial bleed. It's bleeding inside beneath the skin that causes these petechial hemorrhages. The test result normal values, hemoglobin is 72, it's decreased, MCV is okay, WBC 1.5 decreased, platelet count only 10 decreased. So all cell count, all cell line decreased. What do you think? Hemoglobin
aplastic anemia
decreased, platelet decreased, WBC decreased. So we will go for aplastic. For sickle cell anemia, we have to have the sickle cell morphology. Something related to sickle here. It should show peripheral smear, should show sickle cell. Otherwise, we cannot say it's a sickle cell. Hemolytic anemia is just related to the RBCs. It has nothing to do with the WBC and nothing to do with the platelets. Iron deficiency anemia only related to RBCs. So here all cell lines decrease, we have to go for aplastic anemia. Okay, which of the following is the most accurate test for aplastic anemia? Most accurate test.
Bone marrow.
Bone marrow biopsy. For this one, we have to go for the theory. Next, we have Polycythemia Ribrivera. It's a handout. 66 here. So this Polycythemia vera, it's unregulated overproduction of all three cell lines. Again, we are going to see overproduction. There in aplastic anemia, all cell line decreased. Here, it's the opposite. Here we will see overproduction of all three cell lines. Red cell overproduction is most prominent, but it's not like that only you are going to see overproduction of red cell. You will see sometimes WBC very raised, and you will see platelets also very raised. So what is exactly there? Mutation in JAK2 protein, which regulate marrow production. So now bone marrow is under the influence of this mutated protein, and it's keep on producing more lines of blood, more RBCs, more WBCs, more platelets, and red cell grow very widely despite low erythropoietin. Erythropoietin is a glycoprotein which is responsible for erythropoiesis. Erythropoiesis means formation of RBCs. So despite of the fact if the patient is having low erythropoietin, no matter, this mutated gene is there, it's going to go and perform the function of same just like erythropoietin, and it will enhance erythropoiesis. So erythropoietin is also doing erythropoiesis, and this mutated also is doing erythropoiesis. There will be markedly increase in formation of RBCs. Symptoms of hyperviscosity, of course, there will be too much blood cells inside the plasma. The packed cell ratio will be very high. The plasma portion will be off. We know very well that 45% is composed of this packed cells, including WBC, RBC, and platelets, and 55% is plasma. But if too much cells are there, then of course this PCV will be very high. This cell count will be very high, and plasma will be low as compared to that. So we will see more thick viscous blood. So there will be headache, there will be blood vision, tinnitus, hypertension, fatigue, splenomegaly. Spleen is going to capture all these cells, extra cells, bleeding from engorged blood vessels. Maybe their thrombosis from hyperviscosity can be a chance. We can see all these clinical features. So again, we will look for the question. The presentation is very important. And of course, if investigation is there, you can easily rule out. So hematocrit markedly elevated, more than 60%. Normally it's 45%. But if it's more than 60%, think about this polycythemia vera. There will be increased platelet, increased WBC. Erythropoietin is decreased because erythropoietin is a glycoprotein which is regulated and having the same negative feedback mechanism. If more RBCs, erythropoietin will be decreased. Total red cell mass, of course, total red cell will be increased here because of the mutated JAK2. Now you must exclude hypoxia as the cause of erythrocytosis, oxygen levels normal. Here, of course, you should check oxygen saturation, but here in this, it will be absolutely normal because there is not related to hemoglobin or something. It's not morphologically deficient or abnormal here. It's actually the bone marrow who is producing more and more normal amount of all blood lines. So most accurate test will be JAK2 and increased basophil. So these all WBC will be, let's see. If there is too much amount of basophil, what will happen? There's a box written here which says pruritus often follows warm showers. Why? Why after taking this warm shower, those who are having this polycythemia vera, soon after taking shower, their whole body started to itch, especially warm shower. Why? Because this histamine, which is this one irritation causing substance, is released from the increased number of basophils. So there is too much amount of basophil in these patients, and histamine is going to release after taking warm shower. So there will be too much histamine. And histamine is going to cause too much pruritus, too much itching. So that's why these patients always ask to take cold shower, not hot shower. So if we just go for the question. It says a 55-year-old man presents to the clinic with headaches and increased tiredness for the last 4 months. On physical examination, he is afebrile and his spleen tip is palpable. The test result value, hemoglobin 200, it's more than normal. Hematocrit, more than normal. MCV is within limit. WBC, more than normal. Platelets, more than normal. The serum erythropoietin, very low levels. So see, here they have especially mentioned serum erythropoietin. So which of the following is the most likely diagnosis? What you will say here? Myelofibrosis, the term only for the WBCs. Here only, not only the WBCs are raised. Every cell line is increased. Congenital heart disease, it has nothing related to, with the diagnosis of this congenital heart disease, because this spleen tip is palpable, all cell lines are increased. It has nothing related to this congenital disease, heart disease. Essential thrombocythemia, it's only related to the platelets. We cannot say this one. All cell lines increased. Normal erythropoietin is pointing towards polycythemia. Yeah. Which of the following is the most accurate test for diagnosing polycythemia vera? What you will do here?
CBC.
JAK2 mutation.
No, JAK2.
CBC is the initial one. Asking for the most accurate. Yeah.
I just saw 2 options. That's why I
See, this is the main problem. We know the question, we know the answers, but the reading of the question 2-3 times is must before solving it. So never think of any answer.
The 2 options were coming up.
Also, this is one of the psychology. It's one of our psychology. The first thing is comes in our mind is always the right thing. We will always consider. So whenever second time you are the right one, but your mind will say no, the first choice will be the right one. So don't assume any answer. First read all the choices, exclude them, and then say, okay. So here CBC, and look for the most accurate, initial, next appropriate, best next step. Always look for these things. So CBC, liver biopsy, JAK2 mutation, bone marrow biopsy. What's your answer? Most accurate.
JAK2.
JAK2 mutation.
So CBC will be initial and bone marrow nahi hogi most accurate.
No, most accurate test for diagnosing.
Okay.
So that's a clear cut. See, if JAK2 is there, why are you bothered to go for bone marrow biopsy?
JAK2 mutation.
Yeah.
Okay.
Yeah. So if JAK2 is present, it means that nothing to go for biopsy. No need even for biopsy.
Anybody wants to get bone marrow biopsy, they can
then
get.
we'll go.
JAK2 mutation, where will we see?
Yeah, this is a protein. So it's a protein. If you just take this blood protein and you will analyze under microscope, you will see the mutation.
From the blood sample?
Yeah, blood sample. Yes.
Okay.
Okay, so that's all for today. So thank you so much. Inshallah, see you tomorrow. Thank you.
Thank you, Dr. Hera.
Allah Hafiz.
Dr. Hera?